sensory deprivation issue drive that behavior. Okay, so sebab tu kena faham history behind it. Sama juga macam kadang-kadang ada children yang ada behavior related, macam dia play with the genitals, and so sometimes dia bukan sexually driven like adults, and tapi dia maybe sensory related, and ataupun dia punya restricted interest. Okay.
Doktor,
so behavioral tu basically dia punya tingkah laku lah, kan? Tidur, makan, duduk dengan orang lain, emosi, temperament.
Thank you, Doktor.
Question apa tadi?
Kenapa dekat dalam physical examination kita kena cari juga, tengok juga sign of physical abuse ke ataupun self harm? Sebab apa yang doktor?
Kenapa? You rasa?
Kita nak rule out je.
Kita nak rule out. Basically, bila kita buat physical examination, kita bukan sekadar nak tengok cause of the problem. Kita juga nak tengok dia punya consequences of the problem lah. Kan macam bila you assess orang ada diabetes, and you can tengok dehydration, you akan tengok dia punya thinning of the skin, ke you tengok dia punya amputation ke. So that's dalam physical examination juga, kan?
Betul.
You kena take note of those lah. So maybe because of the punya autism tu, parents tak boleh nak manage, tak boleh nak control, dia abuse themselves, ataupun dia ada self-harming behavior lah, kan? Sebab dia ada sensory issue, sebab dia rigidity, so bila whenever dia in distress, dia akan bang his head ke, ketuk kepala ke, so that will result in injury lah. So these are the things yang kita nak tahu. Basically, it's not so much of diagnostic, dia lebih kepada kita nak assess dia punya severity lah. Okay, so later nanti you belajar pasal severity, dia demam, moderate, severe, and so those yang sampai tahap injure themselves tu semua tu, so kita boleh understood lah dia punya severity tu.
Okay, thank you, doktor.
Adalah nak kata most of autism will end up being abused, tapi these are the things yang possible to happen. Okay, Hafizah, habiskan.
Okay, next for the comorbidities and other difficulties. Next, the children with ASD can experience a wide range of difficulties with emotional, attention, and medical problems. The other comorbidities which comes with ASD includes the first one is intellectual disability, which affects about half of the children with ASD. Next is ADHD. And then sleep problem. Almost half of the ASD patients have sleep problems. There's also epilepsy, which range from 7% to 46%. Also gastrointestinal problems. Children with ASD have 5 times more common to have feeding problems. And then the last one is other psychiatric disorders, such as ADHD, emotional or behavioral disorders, and also Tourette syndrome. Next, for the investigation, ASD is predominantly a clinical diagnosis. Thus, children with ASD generally do not require intensive investigation, but audiological evaluation can also be done because most children with ASD present with speech and language delay. Therefore, it is an important component of initial assessment in order to rule out hearing impairment in those children. And for the brain imaging, it is usually considered.
You all ingat hearing testing cukup lah, tak payah tahu detail.
Okay. As for the brain imaging, it is usually considered in selective cases where syndromes or neurological conditions are suspected, and it's usually done at tertiary level. Next, for the management of children with ASD, which includes non-pharmacological and pharmacological treatment. As for the non-pharmacological treatment, we do applied behavior analysis, uh, speech language and communication interventions, occupational therapy, which includes social skills and self-help skills, and other interventions such as social stories, developmental individual difference, and also cognitive behavioral therapy. And then for the pharmacological treatment, in ASD, medications are used in the treatment of comorbid disorders, yang such as stated tadi. And then for the they may be offered atypical antipsychotics as a short-term treatment for their irritability. For example, methylphenidate for hyperactivity, atomoxetine for hyperactivity, and also melatonin for sleep difficulties. That's all for ASD.
Thank you. So there's no medication for ASD itself, but there are medications that we can give in order to control certain behaviors or certain symptoms of ASD lah. So it's more of a kita panggil symptom relief je lah. Okay, sambung. So kalau yang tak pernah tengok autism, just Google je lah. And Google tengok yang educational videos, they'll show you signs and symptoms. So if you have not seen any kids with autism, you can see signs, contohnya speech, echolalia, repetitive behavior, head banging, steaming behavior. And so those kalau you tak pernah tengok, you cannot imagine. Susah nak faham. Okay, sambung. Okay, ADHD.
Assalamualaikum warahmatullahi wabarakatuh. I hope you can hear my voice clearly. So I'll be presenting regarding ADHD, which is attention deficit or hyperactivity disorder. Next slide. So what is ADHD? It is a neuropsychiatric condition affecting preschoolers, not only preschoolers and children, but also adolescents and adults. It is characterized by a pattern of two, which is diminished sustained attention, in which the individual cannot give attention, and increased impulsivity, or in other words, hyperactivity. So this ADHD is frequently associated with comorbid disorder, including learning disorder, anxiety, mood disorder, and disruptive behavior disorder. So although several neurotransmitters are associated with ADHD, the dopamine became the main focus of investigation in the emergence of symptoms. Next. So in context of epidemiology, it is reported to be 7 to 8% in pre-pubertal elementary school children, in which the study suggests that ADHD occurs in about 5% of youth, including children and adolescents, and about 2.5% of adults. So the data suggests that etiology of ADHD is largely related with genetics, in which genetic predisposition increase the risk of ADHD. So in parents and siblings of children with ADHD, it is 2 to 8 times greater than in the general population. Other than that, it is more prevalent in boys, with the ratio ranging from 2 to 1 as high as 9 to 1. And the symptoms of ADHD are commonly presented by the age of 3 years old. Next slide. So this is the etiology of ADHD. So there is 6 etiology, but the most biggest contributor is the genetic factors. So there is marked increase of 2 to 8 times for siblings as well as parents of an ADHD child compared to the general population. So as mentioned before, dopamine are the main focus of investigation. So there is a neurochemical factors which dopamine is the major focus of clinical investigation for neurochemical factors. Other than that, it also includes norepinephrine and adrenaline. So for neurophysiological factors, EEG studies in ADHD children and adolescents have found evidence of increased theta activity, which I have no idea about. And neuroanatomical aspect, there is a decreased volume and decreased activity in prefrontal regions, anterior cingulated, globus pallidus, caudate, thalamus, and cerebellum. So why prefrontal cortex? Because the prefrontal cortex has been implicated to its high utilization of dopamine. And the prefrontal cortex also are related in the components of attention, focusing, and sustaining attention. So for developmental factors, the higher rates of ADHD are present in children who were born prematurely and whose mother were observed to have maternal infection during pregnancy. This situation leads to perinatal insults of the fetal brain. Other than that, and lastly, for psychosocial factor, severe chronic abuse, maltreatment, neglect are associated with certain behavioral symptoms that overlap with ADHD. Next. So this is the clinical features. ADHD have its onset in infancy, although it is rarely recognized until a child is at least toddler age. For infants, we can look at their activities in the crib, where they sleep a little or cry a great deal, and they are easily upset by noise, light, and temperature or any other environmental changes. For school children, the children tend to do a test rapidly, like to answer very fast, but they answer only the first two questions, and they are unable to wait to be called off school. And these ADHD children may respond before everyone else does, even though he have nothing to say. Next. So other than that, I divided clinical features into three categories, which is hyperactivity, attention deficit, and impulsivity. For hyperactivity, we can look for fidgeting and squirming on seats, talking non-stop, dashing around, can't sit still during dinner or school, and they are constantly in motion. For attention deficit, they have very short attention span, and they are easily distracted, and they tend to fail to finish their tasks with poor concentration. For impulsivity, they tend to act before they think, and there are abrupt shifts in activity, and also lack of organization. They also like to jump up and down in class. Next. Next slide. AK, Ain Khalida. Okay. So the diagnosis of ADHD requires persistent impairing symptoms of either hyperactivity, impulsivity, or inattention. These are acquired through detailed history of the child's early developmental assessment, along with direct observation of the child. However, it must be observed in two different settings, either in school or in home. And the diagnostic criteria for ADHD can be referred to DSM-5. It's a long list, so you can look up it in the book of Kaplan and Saddox. For clinical examination, it is divided into two parts. It is first comprehensive physical examination, but the comprehensive physical examination are mainly to rule out medical conditions that mimics ADHD, such as hypothyroidism, hypoglycemia, and petit mal seizure. For mental state examination, we should assess on general appearance and behavior, activity level, speech and language, mood and effect, thought process, social interaction, attention and concentration, and cognitive, which is intelligence. Next. So the management, as I mentioned, the etiology of ADHD is related to neurochemical factors, which is dopamine. That's why we use CNS stimulants in order to compensate that lack of the dopamine. So the first choice of stimulant are shown to have high efficacy, in which their mode of action is to block monoamine transporter and inhibit the uptake of dopamine. So the dopamine can always be there to stimulate the synapse. So this is the example of the medication. Mainly used are the Ritalin. Other than that, there are also dextroamphetamine, which is twice as potent as methylphenidate. However, there are several side effects such as loss of weight, loss of appetite, insomnia, headache. And there is a contraindication which we are never to give this medication to individuals with cardiac risk and abnormalities. Other than that, in pharmacotherapy, there is also non-stimulants This is mainly for ADHD patients who cannot tolerate CNS stimulants, those with severe side effects, and patients with active substance abuse problem. So those are the example of the non-stimulants: tricyclic antidepressant, neuroleptic, and alpha adrenergic receptor agonists. Next. So lastly, other than pharmacological therapy, we go to psychosocial interventions, in which we do academic organization skills remediation for the children. We train the parents how to consult or comfort their children with ADHD, behavior modification in classroom or home, cognitive behavioral therapy, social skills training, and group therapy. I think that's all from me. Any question? I hope not. So we move on to the next topic.
Okay, so for ADHD, pun sama juga. If you have not seen one, then Google je, tengok macam mana. Tapi I think you can pretty much imagine how ADHD would present like. So, kalau you tengok ADHD punya diagnostic criteria tu, dia very specific. Contohnya kalau hyperactivity tu, dia list satu-satu. And cannot sit still, squirming in seats or will lift state. Lepas tu moving around, jumping, running inappropriately, you can imagine. Tapi macam mana you nak differentiate that dengan normal active child? Kalau you tengok ada ADHD tu, sometimes you pun ada je symptom tu, macam mana you nak differentiate it dengan normal? Balik.
Sorry, Doctor, what's the question again?
Macam mana you nak bezakan, how do we differentiate that dengan normal aktif lah.
Normal active
banyak pokok kan? ADHD ke?
So the criteria said it is resistant for 6 months, for at least 6 months, and there is a negative impact on social and academic activities.
So that's dia punya key lah. Number one, dia mesti persistent. Kita pun aktif juga, especially macam kalau you all ni pergi dah lama PKP ni, kalau lepas pergi mana-mana ni memang tak duduk diam punya. Tapi that's it lah, masa tu je lah. Ataupun kids tu only aktif bila bawa kat playground, which is normal lah. Bawa pergi padang, bawa pergi pantai. Tapi in ADHD punya konteks ni, dia regardless. So dia persistent dan regardless of situation. Sebab tu we need more than 2 situation. So kalau dia aktif dekat rumah, kat tempat lain dia okay, kita tak accept it as ADHD lah. And that's because probably dia familiar dengan that place. Ataupun kalau dia aktif dekat sekolah sahaja, kat rumah dia behave, maybe sebab kat rumah mak dia tak bagi dia, mak dia garang. Kat sekolah tak ada orang kontrol, jadi kat sekolah dia aktif. Tapi ADHD ni dia regardless, tak kisah kat mana-mana pun. So persistent, regardless of the situation, and plus impairment in dia punya life lah. Okay, so macam contohnya inattention lah. You all pun sama je inattention kan. Kalau kelas 2-3 straight, lepas kelas kedua, kelas ketiga tu tak boleh nak fokus dah. Tapi later you boleh catch up, later you boleh at least you dapat 1-2 benda. Tapi inattentiveness in ADHD ni biasanya dia akan results in learning difficulties lah. And that is score dropping. Dah 3 tahun sekolah still tak boleh baca menulis. Lepas tu exam tak boleh buat, jawab peksa tak habis. And so that's more damaging to the child's punya academic lah. Alright, sambung.
Alright, Assalamualaikum warahmatullahi wabarakatuh to Dr. Rozanizam and all my friends. Today I'll be talking a bit about intellectual disability. So just an introduction for intellectual disability. It's actually it's another word for mental retardations. But after the Rosas law, they have changed from mental retardation into intellectual disability, and that is what has been written in DSM-5 as well. So, so what is intellectual disability? According to the American Association on Intellectual and Development Disability Association, disability characterized is by significant limitation in intellectual functioning, adaptive behavior, and has to occur before 18 years old. If we look into DSM-5, we have somewhat similar to this definition, in which it is said that it's a disorder with onset during the developmental period, which we can say before 18 years old, that includes both intellectual and adaptive functioning deficit. So what do we mean by intellectual functioning and adaptive behavior? When it comes to intellectual function, it is more to like abstract thinking, judgment, academic learning, and so on. When it comes to adaptive behavior, it's more to like social responsibility, personal independence, right, social participation, and so on. So this is something that we really have to understand, because in other books they also use IQ, and this is something that it is being used clinically as well. Broadly, we will look at the IQ, like how much is the IQ. But when it comes to DSM-5, the one that we are focusing are really just the symptoms, not really the IQ, because IQ can be different. It's not really diagnostic when it comes to this type of condition. We really, and the thing is like our approach to this condition is also according to the symptoms that the patient is having. So when we only know IQ, we can't really do anything about it. But nevertheless, when it comes to cognitive deficit, we are talking about an IQ of less than or equal to 70 plus impaired social adaptive function. So
Is for example, kalau you to understand the concept of intellectual disability, kenapa we need both in order to say that one has disability adalah, kalau let's say for example you take any random orang asli guy yang tak pernah, never went to school, and you go mana-mana, you ambil, you buat IQ assessment. What do you think dia punya IQ assessment put ni? You get low, you get low result. But does that means the orang asli tu ada intellectual disability? No, you kena tengok dia punya adaptive functioning, and maybe orang asli ni punya adaptive functioning maybe much better than you. Kalau you semua saya letak dekat tengah-tengah hutan tu, maybe lepas 3 hari semua mati kering. Tapi orang asli ni dia boleh survive sebab dia punya adaptive functioning very well. He knows which food to eat. He knows macam mana nak get fish from the river. He knows how to get to get direction to go outside of the jungle. And so these are the adaptive components of one's intellectual ability. And so we need to see both deficit baru kita boleh kata one ada intellectual disability. Carry on.
Alright, thank you, Doctor. So about 10 to 15 children out of 1,000 in developing countries have the incidence, with highest being between the age of 10 to 14 years old. I will explain more why this is like that. And when it comes to male to female, there's not such much different, but males are having a slightly higher risk when it comes to intellectual disability. Next slide. All right, so this is a very wordy slide, but I will try to make it simple for you guys.
For year 4, you don't have to really macam hafal or understand every single part of it. It's enough for you to understand, number 1, there are 3 domains, conceptual, example there, and then there are different staging or level of severity. And so we won't ask you in details for each of the domains to moderate macam mana, severe macam mana. We won't go to that details. Just concept.
All right. So the overall concept is most of the ID patients, about 85%, falls into mild category. And when, if we want to look at the flow, when it is mild intellectual disability, we will get to know about it later, like when they are already in their 10 to 14 years of age, or when they are in school, when they are challenged in school, then we will get to know, oh, might be this patient is having intellectual disability. But when it go to profound, it is earlier on, because they can't really talk, they can't really understand. There is alexia, agraphia, so we tend to know it earlier, that, oh, this patient might be having intellectual disability. And when it comes to their if it's mild, later on in their life, they can still get married, and they can still have normal function, somewhat normal functional life. But when it comes to profound, they can't be what is it independent until later in their life as well. So that's the general concept of the of this, from mild to profound. And the other thing, okay, in DSM-5, it is more towards the conceptual, social, and practical domain. But if we look into Kaplan and Seiden, it is more towards according to the ages. So I think that would be easier to understand if you guys want to read further on it. All right, next slide. Okay, so what can cause this? So there could be because intellectual disability is a condition; it's not a diagnosis by itself. So there could be many etiologies. Some can be genetics, for example, Down syndrome, Fragile X syndrome, or phenylketonuria. It could also be acquired and developmental factors, such as a prenatal period, if there if there was any infection, perinatal period, toxoplasmosis, or HIV, or any such problems during pregnancy can also cause intellectual disability. So it can also be acquired childhood disorder, might be because of infection or asphyxia or any trauma to the brain, or to the head, right? And then it can also be environmental and socio-cultural factors, which are nutrition and nurturance, like if the patient is malnutrition, or because of teenage pregnancies, can cause so many other complications in the pregnancy itself, can also lead to intellectual disability. So and when we are taking the history, as doctor has already clarified before, we have to start from the obstetric and gynecology, obstetric history from the mother, whatever happened in the pregnancy, and then up to the development until the age of the patient. Next slide. All right, so that is what we have to cover in the history taking. So family history, and then birth history, any past medical or surgical history, right? And when it comes to assessment of rate and severity, we are looking into the intellectual impairment, or when it comes to the severity, we will look into the DSM-5, any disabilities, the assessment of functioning. So there are many scales that we can use as well. There's Wineland adaptive behavior scales, and so on. And then the impact. So how is this condition impacting the life of the patient? That is what we have to know. And then we will have to know the etiology of it. When it comes to the assessment of current problem, then we will have to do full physical examination to look for any undiagnosed problems, or we have to also look if the patient is unable to communicate, and so on and so forth. And we have to look at the
dia punya facial, dia punya facial appearance. Then we relate that dia punya heart condition and mild intellectual disability is actually associated with certain syndrome, and so we refer to pediatric to do genetic testing. So that is one way and how patients with intellectual disability might present. So if you focus on the end products of the problem, then you might not and see what else is happening. So nevertheless, at the end of the day, we manage according to domains of problems that patient experience. And so most of genetic conditioning has no treatment anyway, but it's worth knowing. And so that by knowing the original problem, then we can look at other areas. And so maybe the same genetic condition can impact patients punya hearing ke, visual ke, sexual ke, GI problems ke. Then those who manage patient as a primary thing, we look into those as well. And so instead of just focusing on one problem, which is reading, writing, and calculating, we know that there are other issues that we need to look at as well. Okay, carry on.
All right, thank you, Doctor. Next slide. So when it comes to differential diagnosis, it's not really a differential diagnosis, but what we have to really look at is if the patient is, neglected or if there is any abuse. Because when, let's say, that it does not supposed to cause intellectual disability. So when the patient is abused, might be at that time there seems to be intellectual disability. But after that, when the patient gets the support and gets gets cared of, then it is somewhat like reverses, so the patient can do well actually. And then again, we will have to look at sensory disabilities. If the patient can really see, if the patient can really hear, so this can also become a factor towards the intellectual disability. And then we have to look at the expressive receptive speech disorders, or if there is actually specific disorder, might be the patient is having alexia, which is agraphia, aphasia. Alexia cannot read, agraphia cannot write, aphasia cannot speak. And then we have to look at we have to differentiate this with learning disabilities. So might be sometimes learning disabilities is only in some particular parts, but when it comes to intellectual disability, it's like as an overall, they can't really do anything. And this is also coexist, as it was explained before, it coexists with autism spectrum disorder. So we have to know, like, is it really just intellectual disability, or is it ASD with ASD? And then when it comes to dementia, so these patients can have somewhat dementia as well. So if it is less than 18 years old, then we will call it dementia plus intellectual disability. But after 18 years old, it will only be dementia. We don't consider it as intellectual disability. All right, next slide. So how do we treat? So is there any medicine to make someone better or intelligent or increase IQ? I'm afraid not. It will be great, I guess, but no, there is no such thing yet. So when it comes to prevention, the primary prevention, as was said, might be we can do screening, immunosynthesis or chronic Willy technique, so during the pregnancy. So that is the primary prevention, or so we can screen babies for PKU, and then to educate the mothers not to take alcohol during pregnancies. Okay, so this can play a major role. Then for secondary and tertiary, sorry, for secondary is like we have to do prompt attention to the to diminish its course. So like when we get to know that this patient might be having intellectual disability, we have to like do take the interventions as early as possible to diminish its course, and its course can be diminished. And for tertiary, we will try to minimize the sequelae or the consequence of the disabilities. When it comes to psychosocial intervention, we can do some educational interventions. So like there has to be comprehensive programs for this type of children. More attention has to be given to their communication and to improve the quality of their life, right? And then to address their academics, training in adaptive skills, social skills, vocational skills, and so on. When it comes to behavioral and cognitive behavioral interventions, we can, there can be psychodynamic therapy, there can be cognitive therapy, and so on. So this is also to to reduce the conflicts about expectations and to reduce the anxiety, rage, or depression, and so on. So another thing that we have to understand is in mild and moderate intellectual disability, the patient can like feel that might be the parents are not as proud, or might be their siblings are doing better, or what the society wants from them is something else. So this can also lead to feelings of depression, anger, anxiety, and which can lead further to comorbidities such as MDD and so on. So this is something that we have to like really take care of as well. Family education is really, really important. So it is to it's a way to enhance the competence and self-esteem, and maintaining realistic expectations of the parents as well. And there should also be from time to time the counseling sessions for the parents themselves, or a family therapy, for the parents. Like it can be really stressful to be having and to be taking care of a child, of such child. So they also need the relevant counseling. For social interventions, there is something known as the Special Olympics International. So this is like Olympics for this type of patients. So to increase their self-esteem and for them to be confident by themselves, for them to make their own friends, and to show that they are worth it. They still can do what if they want to do it. When it comes to psychopharmacologic interventions, it depends on like the behavior of the patient. So for example, if the patient is aggressive or irritable, or there is some sort of self-injurious behavior which we can find in profound intellectual disability, then we can give antipsychotics or antioxidants and anticonvulsants. So similarly, if there are like depressive disorders, then we can prescribe it SSRIs. So it really depends on the condition of the patient. And there are some other services and support that we can do, like first of all, early identification. And then the early identification is in the first 3 years of life actually. And then for school, from 3 years old to 21 years old, to give them the education that they need in a way that that is beneficial for them, which is suited for them, right? So and in a least restrictive environment, right? And there are also support groups, organized groups and services for the parents, for the family, and for the patients, right? So this is really superficial, I think, explanation about intellectual disabilities. There is way more. And intellectual disability is a topic with many more topics in it, in some of the books. So you guys can always read it. Yeah, so I think next slide. I think that's all from me. There's just a video that I would like everyone to see.
My life took a different turn when I discovered that two of my children had special needs. Noel, my eldest child, lost his language and stopped speaking at 2.5 years old. He had very poor focus and attention. He did not understand special expressions and social cues. He had a lot of struggles in day-to-day situations. Joshua, my second child, had a very severe autism. He did not respond to his name. He did not have eye contact. He did not understand our words or who we were. When we tested him, we found out that his IQ was less than 30. As a mother, I was heartbroken. But this was what made me stronger. I decided to do something about it so they can have the future they deserve. I tried every means I could find. This therapy and that therapy, which doesn't work. I need to do something. Then I went around the world to look for an answer. With the support of my family, I embarked on a journey that spanned over 10 years and 3 continents on how to help them. From countries to countries, from hospitals to clinics to research laboratories. And I found pieces of the jigsaw puzzle, one piece at a time. After traveling to many countries, reading hundreds of studies, and learning from the many experts, I discovered the answer. It wasn't any drug. It is nutrition. Yes, what they take in can change their life around. Nutrition that can put out the fire in the brain, and nutrition that can build back the brain. I also found out that drilling method doesn't work. You need understanding and patience. The right kind of attitude can help them with the healing of their brain. Many times, parents are in denial of their children's condition. They might have a lot of fear, embarrassment, or anxiety. With a change of mindset, parents can motivate their children to want to be better. When parents change, children will change. That's how we can help our children to regain their awareness, to give them their speech, to connect them with their loved ones and the world around them. Now my kids are recovering. My second son knows who we are. He has memory and he can study. He is able to go places and he is connected. My eldest child is now completely normal. He would say, bye-bye, autism. Whether they have autism or not, every child has the potential to achieve great things, and they have the right to try. The healing process is not short. It might be long and tedious, but it is rewarding and it is meaningful. I am Dr. Devi Mamahit, and I'm happy to be your partner in your child's healing journey.
Alright, so why I was showing that video was because just so you guys can know what are the struggles of a parent, when they are having such child. I'm not so sure about her methods, whether they are like, but if you guys want to read more about her research, you can. But yeah, so this can be something very devastating for parents as well. So it is really important to to give them the education on how to really take care of their child and to support their child wherever they are at, right? And as a society as well, there's a lot of stigma about this. So that is what I just wanted to portray to you guys. Hopefully it was beneficial. I think that's all for me. Is there any questions?
Okay, thank you, Asnain. Just be careful. I tengok video tu, I rasa macam dia nak jual produk je tu. So you have to be careful. Especially when dia guna terms macam apa namanya, cure, betul recover from autism. So be careful dengan your source lah. Tapi the highlights of the struggles and everything tu betul lah. Okay. Sebab I don't know who she is and apa behind it. And so at the moment, evidence-wise, there's no, even nutrition pun there's no specific dietitian or nutritional approach to manage autism anyway. Okay, thank you. Ada lagi, there'll be another 2 topics, tapi saya nak carry forward that 2 topics to masa dissociative lectures ya. Boleh? Sebab dah 12:50 dah. So sebab dissociation tu nanti saya nak just bagi you all video lectures for you to watch on your own first. I'll give the slides as well nanti. So kita just discuss je pada dissociation tu. Untuk jadi kita ada extra time nanti kita completekan the other 2 topics for child. Boleh lah?
Boleh tak?
Okay. But any questions for the first 3 topics ni? Any other questions that you want to ask?
So, Dr. I want to ask,
Silakan. Yes.
For example, in autism, both pediatrician and also psychiatrists manage the patient, right?
Yeah.
So, in what aspect that they manage it differently or what?
Okay. So basically, assessment or confirmation of diagnosis is done by either psychiatrist, pediatrician, or developmental or clinical psychologist. So these are the only professional yang boleh confirm the diagnosis per se. Tapi management, when it comes to management, sebenarnya dia multidisciplinary and tak ada any single parties yang manage autism ni on their own. So as you can understand, autism ni dia ada a broad spectrum of symptoms, and so each aspect tu will be taken care of different discipline. So for example, the sensory issues that will be under occupational therapist, the speech and communication under speech therapist, and the behavioral component under psychologist and psychiatrist. And kalau sleep, GI problems semua tu, pediatrician will look after. And tapi there will be one discipline yang akan oversee the whole. And tengoklah siapa dia punya primary care for the child. And kalau dengan saya ni psychiatrist lah. And so I will oversee the development, the progress of the child overall. And so initially we might see them fairly frequent untuk confirm the diagnosis. But once diagnosis being confirmed, basically the punya management tu will go on. And macam terapi, it will take time. And it will be involved multiple sessions, and ada yang bila dah besar sikit masuk special education, and so semua ni ongoing. Okay, and so macam sensory issues, there will be different sensory integration therapies, and for motor, for cognitive, focus training, they will be different. Tapi kita akan oversee the development. So if at any point contohnya child ni ada significant behavior yang require medication, kita akan treat accordingly. Macam tu lah. So dia bukan one off or 2-3 weeks punya assessment lah. Yeah. Okay, so true enough, macam like what we discussed earlier, autism ni comes in spectrum. So ada yang mild, moderate, severe. So for those yang severe, moderate, so parents might notice them earlier, so they come to seek assessment earlier. Tapi there are also autism yang mild. Mild ni basically the symptoms tu may be very subtle to the point that it may not be substantial enough to impair the function. And so remember, autism ni is a spectrum, and so spectrum ni maksudnya dia datang in range. Okay, so range. So dia tak ada macam black and white condition. Dia bukan macam myocardial infarction and diabetes, very black and white macam tu. So dia datang in range. And so there are cases yang mild autism ni yang got underdiagnosed or misdiagnosed when at early stage. Sama ada sebab parents tak bawa ataupun parents do not think that it is significant enough. And then later bila adult baru dia presented. So it happened, tapi regardless of when the presentation occur, we treat it accordingly. So I give you an example. There are patients yang datang dengan depression, for example. Age 18 ke 20 datang dengan depression. And so bila datang dengan depression, of course one of the things that we will find out, we want to know adalah apa dia punya stressor. And so ada patients yang dia punya stressor tu make us wonder whether this is actually related to dia punya certain skills yang dia tak ada. Contohnya, and the students tu depressed sebab apa? And dia rasa dia left out, orang tak nak kawan dengan dia, orang kata dia pelik, and orang bully dia. So there must be a reason why 18 years old got bullied, 16 years old got bullied. And so bila kita explore and kita tengok cara dia cakap, cara dia punya reasoning, dia punya behavior, dia punya interest, then only we might see that this is actually pointing towards an autism, for example. And so this is when kita go back to history, and then maybe mother dia kata, oh betul dia ada lambat cakap, tapi at the age of 5 tu dia dah start boleh cakap semula. Oh betul, masa kecil dulu dia suka main sorang-sorang, tapi saya ingat tu biasa je, lagipun dia anak tunggal contohnya. And so sometimes things got overlooked and menyebabkan the diagnosis tu did not occur in the first place. Tapi, and of course bila dia dah besar tu, kita treat dia as an adult lah. And so kalau dia depressed, kita treat dia punya depression. Kita tak adalah buat play therapy ke, kita tak adalah buat kita manage dia according to apa deficit dia then pada waktu itu. So kalau deficit dia adalah social skills, then kita refer dia for social skill training. Kalau deficit dia in intellectual, then kita do what's needed accordingly lah. I have a pediatric nephrology professor when I was a medical student dulu yang ada autism. So he has Asperger's syndrome. And so he's very smart. And tapi memang very awkward socially lah. And kalau dia present tu dia cakap sorang-sorang, baju pun terkeluar sebelah, tu jalan pun macam tak ada jalan macam very robotic. Tapi he's very smart in his fields lah. And, tapi dia memang tak functioning lah socially kan, macam tak ada kawan seseorang macam tu, tapi they can survive. Okay. You all semua tengok The Good Doctor kan? Tengok The Good Doctor.
Tengok.
So that's Good Doctor tu of course TV punya lah, TV. Sebenarnya to me, to be honest, I don't think patients yang ada autism ni boleh jadi surgeon lah. And I don't think dia punya capacity tu boleh. Bukan sebab dia tak pandai, tapi I don't think the work tu macam suitable for them lah. And maybe you'll see macam autism ni dia akan end up kerja as engineers, IT, auditors, and sebab dia very rigid kan, an accountant, and it suits them. So dia tak disturb dia punya function lah. Tapi kita tak jumpa lah autism ni kerja as entertainer ke, autism kerja as travel agent, yang very social oriented work kan. Okay. Alright. Let's stop here dulu lah. Kalau ada any question, then we'll carry on with the discussion later. Okay, thank you.
Thank you, Dr.